Excellent. Okay, so I am really excited to introduce Dr. David Rhew, who's the Global Chief Medical Officer and Vice President of Healthcare for Microsoft. David has served as Microsoft's international coordinator for the pandemic response during COVID-19. He worked with the World Health Organization to develop their World Health Data Hub, CDC to stand up their vaccine data lake, and US states when they were rolling out the COVID-19 vaccines. He is adjunct professor at Stanford University, holds 6 US technology patents that enable authoring, mapping, and integration of clinical support into EHRs, and has been recognized as one of the 50 most influential clinician executives by Modern Healthcare. Please join me in welcoming Dr. Rhew.
All right. Can you all hear me? Is the mic on? Okay, excellent. Well, first of all, it is a real pleasure to be here. Thank you for inviting me. Thank you for inviting Microsoft. This is a fantastic event, and I am wanting to share with you not only some exciting things on AI, but I'll just tell you a little bit about myself, something that Albert didn't have in his bio. But in 1988, I was an undergraduate, and my major was computer science. So I had to write a thesis, and my thesis was AI in healthcare. This is in 1988. Okay, so back then, nobody cared. My family, my friends, they didn't care. I applied for medical school. None of the medical school people were impressed. And I honestly didn't think it would actually be as exciting as it is today. So fast forward to today, everybody cares. Everyone's talking about AI. And what's the difference? Well, the difference is, one, technology has dramatically improved. It's become easier to use, it's become more advanced, but also within the healthcare perspective, things have been changing. And while we're heads down, focused on clinical research, taking care of patients, doing all the things that are necessary to make the organization the best organization possible, the landscape, the ground is changing underneath us. And so what I want to do is I want to talk to you about what are we seeing that is allowing us to make that conclusion that the landscape is changing and that we should act, that there is a sense of urgency to act now, because ultimately other organizations are starting to realize this. The industry is recognizing it, and we may be able to solve problems that we could not have solved before. So Rohit started his discussion with, we've got some big challenges. We've got rising cost of healthcare. We've got clinician burnout in the workforce crisis. We have issues related to access to affordable healthcare. There may be an opportunity for us to apply the technology in ways that will help us solve these problems, which before were very difficult to solve. So in order to do that, let me just kind of go back in time, because I think it's always worthwhile to understand our journey in the technology space. And everyone talks about AI, but the reality is AI is not new. It is something that has been around for a long time. If you think about when it was first coined, it was first coined in 1956 as a means to describe how a computer could act like a human. And that idea of how a computer could act like a human is something that we realized you could start with algorithms, simple if-then statements, and be able to create decision trees. But we started realizing that we could actually use the data to help us inform the algorithms so that we could learn. And that process of learning from the data is what we call machine learning. And so this combination of AI plus machine learning has been going around since the 1950s. Well, that also has progressed. And while I'm going to talk about 2 paths that have emerged, one is around the traditional AI ML. There's another path that has come about because we started realizing when we put the data together in what we call neural networks, when we start looking at the concepts, we realize that certain concepts are bunched together. And so from a mathematical standpoint, we put greater weight when we see concepts that are associated with other concepts. So that allows us to be able to make decisions that this is the most likely node, this is the most likely word, this is the most likely pixel associated with that. And from that process of leveraging the neural networks, we have then created something called generative AI. Now, generative AI has been around fairly recently, since 2021. But what has happened is that when we use these models on very large data sets, which had a lot of inherent knowledge in them, we could extract that knowledge and we could make that available. So I mentioned that there's two tracks because in parallel to all the attention that generative AI has been getting, we also realized that traditional AI ML has slowly but steadily made some dramatic improvements. And so this is maybe one of the most underappreciated things about AI. We are actually realizing that AI ML is getting to the point where we can also do things that we could never envision, specifically in the area of natural language processing, things that we always assumed a human could do, understanding voice, taking a look at an image, being able to understand an echocardiogram. These are things that images, voice, text, we always said a human had to be using that. We can actually use AI ML to be able to do that. So this combination of tools that we have is really what AI is. AI is not about one tool, it's about a combination of tools. Imagine you're building a house and you only had a hammer. Well, it's hard to build that. Now imagine you had a hammer, you had a wrench, you had power saws, you had a power, that's what you have. You have the whole suite of tools within AI. And it's important for us to realize when to use the right tool for the right problem. And what we realized is that the problems themselves are not as simple as we've got one problem, use the one tool. In fact, when we talk about something as simple as ambient clinical intelligence, which Rohit mentioned earlier, which is the AI scribe. Well, if you break that down into the various steps, what's the first thing that happens? The AI is picking up who's talking. That's actually, it has to know where it's coming from. And it listens to the tone of the voice and it says, this is person one. And then this is person two. And then from there, it is able to identify the words. And the words then are codified on the back end to various terminologies, which we refer to on the medical technology side as like standardized terminologies like SNOMED or ICD-10 and things like that. But there's a variety of other terminologies as well. And so it's mapped on the back end. All of that is traditional AI ML. The ability for us to be able to listen, identify who's speaking, codify, understand what the words mean. Now we are putting that together in a note. That's generative AI, and then it has to get integrated to the medical record, and that is traditional technology. So think about it, all those different steps, all stitched together, that's what we're solving for. And it's a combination of all of these things that allows us to be able to solve these very difficult problems. Now, one other thing that's happened, which is really interesting, because if it was just that, it would just be computer scientists that are all excited about AI. But something else has happened. And one other thing that's happened is that we put a natural language interface right in front of that AI reasoning engine, which means that every one of us, our family members, our patients, our administration, can access this in the exact same way that a computer scientist used to be able to do. That's what's transformative, because we have democratized the AI. All this amazing technology before was behind this wall, and we said, well, we have to use our smartest data scientists. We actually, as researchers, clinicians, and administrators, and people taking care of patients, we can actually do more with the AI than we could ever have envisioned before. And I'm going to share with you several examples. Okay, so let's talk about what could be done. And this is a kind of, I'll call it a framework for how we can think of AI. So think of it from, and most people think of it from the clinical perspective. There are so many challenges in the clinical perspective, but one is around experience. And a lot of that experience has to do with the fact that patients and clinicians are overburdened with administrative things. As a patient, you're asked to do all these different things. My mother-in-law, she has undergoing a colonoscopy this week. They gave her a whole set of instructions, impossible to follow. They said basically, can't have any fruits and vegetables and grains and can't have liquids. What are you supposed to eat? It's like everything you can't do and nothing that you can do. It's really hard for patients. You got clinicians interacting with the patients, and they're trying to do all the stuff like documenting to the EHR. They're trying to answer emails. Very difficult. So one category, clinical. There's a lot of stuff. Research. We don't spend a lot of time talking about this, but boy, this is transformative. We work with a lot of pharma life science companies that their entire business model is building that blockbuster drug. And they spend billions and billions of dollars on this particular activity to find new receptor sites, to be able to then figure out what that new generation drug is going to be. How do they do that? A lot of it's actually very manual. And for those that are researchers, you know that a lot of it has to do with hypothesis generation, testing it, then figuring out and then adjusting. Well, how do you generate hypothesis? You look through all the literature, you look through all your data. Very manual. You actually now have mechanisms to pull that. In fact, there was a great example one of our clients shared with us where they talked about they were trying to identify this protein and they wanted to create this model. And they wanted to show through the AI that they could actually do this faster. So they used traditional AI ML to be able to then help them on this journey. Now, originally they were using standardized approaches, and it took them a lot of time with a lot of compute power to be able to get a partial fold model for this particular protein. And they estimated that if they were to continue to follow this model to get to that next level, which was exponentially higher to the complete fold, it would have taken them 1,000 years. That's impossible. Basically, no one's around 1,000 years. But they said that that's really our trajectory. They were able to do it in less than a year with the AI capabilities that they have today. And that just shows you what was previously impossible is now possible. With training and education, we are going to see a brand new workforce come in, a workforce that is expecting technology, that is expecting AI, patients that are expecting. We have to find ways to educate everyone within the workforce and our patients, and there's a whole transformative effort around that. One thing that we're going to recognize is that we don't want to leave people behind. While technology is advancing, there's a very important need for us to think about equity and allowing us to ensure that individuals that are in underserved communities, the vulnerable individuals, don't get left behind. And we have an opportunity to improve access to care, to be able to change our way that we communicate with individuals using the technology to translate into their language at their grade level, be able to present that information in ways that are meaningful. And then operations, critical. In fact, this may be the low-hanging fruit. I'm going to spend the first moment just talking about some of those operations, because if you want to talk about high impact, low risk, a lot of stuff in operations. And throughout this whole process, we have to do it in a way that fosters trust. There has to be responsible AI embedded throughout. So I'm going to tell you a little bit about that. Cleveland Clinic is part of a network called the Trustworthy and Responsible AI Network, and there's a lot of exciting activity. I think you all need to be aware of it and hopefully get involved. Okay, so let's talk about operations. This is one that I say is probably the most common question that comes up. What can we do today with this new AI, this generative AI in particular, that will allow us to be able to help show an immediate ROI? Well, I'm going to give you an example. So let's start on the left-hand side, reimbursement. Well, one of the things that's happening is that denials are on the way up. It's unfortunate, but that we see this all the time. And what does that mean? Clinicians have to go back and forth. There's a lot of paperwork, a lot of exchange of information. This can be automated. There's a lot of processes that allow us to be able to help improve that. So Emory Health System. Emory said, well, what we're going to do is we're going to create a new office or a new position. We're going to take a surgeon and we're going to create something called the Chief Financial Information Officer. And they're going to focus on using AI and data and technology to be able to help us address issues around reimbursement, revenue cycle management, all the things that we know are problematic. Year one, $82 million in realized revenue. Just a simple example of how focusing on something that's a low-hanging fruit, tremendous opportunity. But it wasn't just the technology, and this is one of the key lessons. They said that a lot of this has to do with communication with the surgeons and the other clinicians, because without that peer-to-peer physician communication about what's going on, none of this will get done. And so there has to be that coordinated effort. So when Rohit was talking about there's more to it than technology, absolutely. And a lot of it has to do with people, culture, process change, and making sure that we're all on the same page. Because when you do those things, it can really improve operations and lead to great results. A lot more to cover in this, but I only have 30 minutes, so I'm going to go fly through a lot of this and leave time for Q&A. Okay, so let's talk about those high impact use cases. Now, there's a lot of them, but because I want to just make sure that we cover some of the big ticket ones, I'm going to cover 4 things, and then we're going to go quickly through this. Clinician workforce crisis. Okay, we know that this is a big problem. How big a problem is it? The National Academy of Medicine said that this is last year is going to be one of their top priorities. They're going to put together a workforce and they're going to figure out how can we solve this problem collectively. And so they asked us the question. They in fact asked me to provide a presentation about, we know technology can add burden, but can technology decrease the clinician workload? And they gave me 5 minutes to present. So I said, okay, if I only have 5 minutes, I'm going to create one slide that's going to have everything in there. And this is the one slide I shared. I said, there's 3 things that I would focus on. The first is there's a lot of stuff that clinicians do today that is very administrative in nature, whether it's documenting into the electronic health record, whether it's answering emails, whether it's filling out forms. That process can be automated. And we should focus on ways to take the technology and apply it to things that we know are automated. But if we just stop there, we are missing the boat. Because in many cases, the things we're automating shouldn't be automated. In fact, I was asked by one group, they said, oh, we've got this great idea for the generative AI. We're going to have our nurses, or we're going to create this generative AI tool so that when the nurses do their shifts, their handoffs, we're going to summarize it, and we're going to put it into a note and say, here are all the different tasks from the last shift that you can do for this shift. And so the question I asked them was, so on that list, how many of those things could be done by someone besides the nurse? And they're like, that's a good idea. We hadn't thought about that. In fact, if you think about it, that's probably one of the first things we should be thinking about. Can we use this opportunity to redesign the process so that the work doesn't always go to the busiest person on the floor, that it actually goes to the entire team? We redistribute it. This whole concept of load distribution, redistribution is so important. And in fact, it may be one of the most important things that we can do for AI. When we think about like big problems, National Health Service in the United Kingdom, NHS, big system, they've got one big problem, and that problem is patient wait times. What does that mean? Patients are waiting for their surgeries. They're waiting for the procedures. And sometimes they're waiting for months, years. I mean, it's crazy. That's the system. And they're like, we have a big problem. One of the things that they've been doing is they're looking at AI to reduce that wait time. How are they doing that? They looked at that list and they said, okay, of these patients that had this total hip replacement that they needed this particular surgery, let's think about what the process was. The surgeon or the GP said, you know what, this is something that requires a procedure. Let's send you over to that big center, that big academic medical center, which does this all the time. They're super good at it. And we're going to put you on that list. Sure enough, that list is super long. It's over a year. And what they looked at was, we have a lot of hospitals affiliated with that particular organization. They had wait times that were dramatically lower. And the procedure was actually something that could have been easily done there. How could we figure out a way to redistribute it? So what they did was they said, let's take a look at that list and let's assign people or these individuals so that they actually, rather than going sent over to that big tertiary care center, they started sending it to the different satellite hospitals. And they found that that actually redistributed the load. And we see this all the time. Healthcare is by inherently inefficient. It's not designed for scale. And when you start adding more and more people to it, you get pressure points and it bottlenecks. It bottlenecks all the time in every single thing we do. And those may be one of the greatest opportunities for us to play AI, where we can redistribute the workloads to improve the overall efficiency. Now, if we just stop there, we've also got another problem. And if you've ever been in an ICU, which I know all of you have, you know that there's a lot of beeping going on. And how many times are you hearing the beeping and people running and saying, oh, I've got to address that? Never, because we've ignored it. Because the beeping doesn't mean anything to us. Because the beeping is more FYI, hey, there's something going on, which we already know about. But every once in a while, there's a beep that says, hey, there's something really critical you better take a look at. And unfortunately, it all gets washed. If we don't figure out how to address that issue, patients are going to get harmed because of the fact that we have an inefficient, ineffective system right now. And so we have to figure out how to better address that. So these are 3 categories. I wish I could say that AI could solve every one of them, but obviously it's a combination: AI, process change, culture, et cetera. Okay, so let's talk about proactive care, because this is something that we always talk about, but we really rarely understand how could we actually deliver proactive care. And what is proactive care? It's the opposite of reactive care. It's the opposite of what we're doing today. So who comes to the hospital? Who comes to the ER? It's a person who has a symptom. They have something going on. Or they've got an appointment that they need to get their meds refilled, or they have something else coming up. But they've been told, or they've been informed that they have to come in, or they feel that they need to. By the fact that they have a symptom means that something's going on. What we want to do is we want to be able to go upstream before they got the symptom to know this is a person that's at higher risk for a particular area, but really not just so to say that everyone's at high risk, but to really know that this is a person who within the next week, the next few months is actually heading in that wrong direction. How can we anticipate that? Okay, well, let's think about the things that we do every single day. Well, one of those things is that we do a lot of images. A lot of images for people. Now, there's a couple things with images. Sometimes with these images, there's information in there that we have not looked at that we don't even realize is extremely valuable. That's one thing that happens. Now, the other thing that happens is sometimes we focus on one thing and we miss the big picture. These are things that happen every single day. I'll give you an example. Person comes in with a pneumonia, a cough, okay? Goes into urgent care, gets a chest x-ray, rule out pneumonia. Everyone has to write rule out something or other, right? Because that's what the radiologists are looking for. Rule out infiltrate, rule out pneumonia. They don't find it, but unfortunately, there was a fracture that was missed. Well, how often does that happen? Well, if we only spend our time in the inpatient, where the radiologists spend a very meticulous amount of time to go through every single one, you might say it doesn't occur very often. But when you go into the ambulatory space, it occurs very often. In fact, in one study at Covera Health, they found that 62% of the time that these radiographs were being done, they were missing critical things in particular that were underrepresented or underreported in these reports. And what we're finding is that in Medicare patients, 13% of them have osteoporosis or a compression vertebral fracture that's present on imaging. That's our target audience. And what they found is in this particular analysis, they did the imaging, they identified it, and they brought the people to start them on calcium, bisphosphonates, started them on an exercise program, and they actually found decrease in the overall long-term results of decreased fractures and lower cost. This is the opportunity. That's just using imaging. Now let's talk about something that we rarely, if we ever talk about. How can we actually assess images of an individual without actually going and having them go into a radiology unit? Well, we do this all the time. So many of us, if not all of us, have had our eyes checked. You know the machine. You sit down, put your chin on it, you look in this thing and it says, is it better or worse? That's the machine I'm talking about. Okay, that machine typically captures an image, and that image is something that is on that machine, and after the image you're done, it's basically lost forever. Well, now what's happening is they're actually moving that image to the cloud, and they're running AI on top of that. And because they're doing that, we now have an opportunity to do things that we have always thought were theoretically possible, but now are possible at scale. So we are now finding that organizations can apply AI on top of this to be able to screen for conditions. Let me give you an example. Stanford in Palo Alto, big medical center. They have a lot of satellite hospitals, or clinics throughout the entire region. Many of them are in rural areas, community-based centers. And what they decided to do is they said, in these community centers, what we're going to do is we are going to, as part of routine vital signs, everyone gets an eye checkup. And as part of that eye checkup, there's a DICOM image that's taken, and they're going to run the AI specifically screening for diabetic retinopathy. And they're picking up a ton of retinopathy in these patients. And what is happening, their patients are actually going to see the eye specialist, and they're getting treated, and their HEDIS score, which was the lowest of all the different HEDIS scores, screening for diabetic retinopathy went from the lowest to one of the top. Why is that? Well, think about it. First of all, they're finding it. They're finding the retinopathy, which is the first. But the second thing is, if you're a patient and you said that you've got diabetes, it's a good idea for you to go see the ophthalmologist because it's just the right thing to do. Most people, if you live far away, it's going to be hard. And that's what's happening. People, they don't see the sense of urgency. Now, the message was different when they got this. The message this time was, hey, we picked up something. If you don't go see the ophthalmologist, you'll go blind. A lot of people saw the ophthalmologist. It's a different message. That's what we're doing. We're screening across a large population for these conditions. And on top of that, diabetes is just one of the multiple conditions that can be applied. Cardiovascular disease, hypertension, hyperlipidemia. These are all things that are right around the corner in terms of FDA clearance. And then on top of that, you've got things like Alzheimer's, chronic kidney disease. In fact, there's a great study in Nature where they found that patients that had chronic kidney disease, when they looked in the eye. And by the way, what we're talking about is we're looking at a micron level at the arterioles and the nerve vessels and the surrounding structures. This is better than any type of imaging you can envision. I mean, at the micron level for these, that's why we're picking up these diseases. Looking there, they found that the choroidal and retinal thickness correlates directly with the glomerular filtration rate. And so they saw this because they saw chronic kidney disease, patients had worsening renal function, and they saw thinning of the choroidal and retinal thickness. And then they got transplanted, and it increased, dynamically associated with that. Okay, looks like I'm gonna have to fly through this. Okay, one other thing about the Stanford, because the screening was done CPT enabled, the physicians got paid for the screening, the ophthalmologists got paid for the referral, the HEDIS score went up, which ultimately led to higher reimbursement. And of course, the patients get better, greater access to care. It's like one of those rare examples that you get all those things working together. Another one, we talked about ambient clinical experience. What about that voice recording that was captured? Could we do something with that beyond helping the clinician? Well, there is something. In fact, at Intermountain, what they're doing is they're actually using that voice and using voice as a biometric. And they're assessing for individuals for their anxiety, their depression. They're trying to figure out, is this person depressed, anxious, and then quantifying it so they can track over time. They're even doing this for the clinicians, making sure that the clinicians are not burning out. Okay, very quickly, let me just quickly go through precision medicine. I was given the wonderful opportunity to join an initiative called the Biden Moonshot Initiative. And there was a meeting that we had at the White House on March 10th, and two speakers spoke at the very beginning. Simone Bozeman, Craig Melvin. Simone Bozeman is the widow of Chadwick Boseman. You may remember from that movie, Black Panther. Craig Melvin is a Today Show host. He had a brother named Lawrence Meadows. Both of these had siblings that died of colorectal cancer at a very early age. Why did they die? Well, you would say, oh, it's lack of screening. They were in their 40s. They had no symptoms. They would have missed by regular screening. This is a gap we have. We apply screening guidelines for populations, but we miss individuals that are high risk. Why is that? Because if you look at colorectal cancer, they started off with a genetic predisposition, and then there were a series of mutations that occurred. And why did the mutations occur? Because they had exposure to a variety of different things, usually environmental, food, exercise, all these other things. And if we put that into one category, it's social determinants of health. So what if we were to think about this scenario where, back to the data, we were to capture all the data, but we are capturing it holistically and longitudinally for individuals across not only what you have in the EHR, but what they're doing on a daily basis, their social determinants of health. We could actually create a much better holistic picture of the individuals. And with that as a starting point, with the longitudinal nature of that, looking at outcomes, we may be able to visualize how individuals will progress over time. We may be able to cohort individuals to say that I'm interested in individuals that have this particular condition, that have gone through this experience, and I want to know what their prognosis is, and you can predict whether or not they'll actually head in the right direction. That's the future. That's what research centers like Hopkins are trying to do. This is what research centers across the country, they're all trying to do. They're starting with the data, they're pulling together, they're creating an infrastructure that supports that. Let me lastly talk about responsible AI, and then I'll open it for questions. So as I mentioned, Cleveland Clinic joined a consortium that was launched at HIMSS March 11th, and it's called the Trustworthy and Responsible AI Network, TRAIN. Now, a lot of people say, well, why join another consortium? There's so many out there. Well, let me just tell you a little bit about what this is. So there's an organization called CHAI, the Coalition for Health AI, and they have pretty much said that these are the key principles that we need to adhere to, things like transparency, explainability, governance, value assessment. Question is, like, how do you implement that within your own institution? And that's what TRAIN is trying to figure out. And if you were to boil it down into four questions would be, do you know all the AI that's running in your system today, both first party and third party? If not, probably a good opportunity to do that, registration. Second, have you tested it on your own local data sets? If you haven't, and you're just assuming that it would work in somebody else's environment, you'll be surprised. It doesn't always work. And then if you find that it works, is it working even after deployment? Because there's something called drift. And while AI is fantastic, it changes over time, and the environment changes, and ultimately you may find different results. So local testing is important. Bias. Have you looked for bias? Because there is bias. It's based off the original data set. But if you haven't looked for it and you haven't found ways to mitigate it, you're likely going to run into problems down the road. And the last is, do you have a governance process? And is it scalable? These are 4 basic questions, but we're trying to solve that with Train. And ultimately, if we think about like what is it that we're trying to do? This is what we're trying to do. Starting at the very top, we want to figure out what our use cases are. We want to identify the risks associated with it. We want to choose the high impact, low risk use cases. We want to figure out what's performing best, because we don't want to choose the most expensive, worst performing algorithms. We want to choose the best performing ones. We want to choose it so it's cost efficient, time efficient. We need to get it into the clinical workflow and operationalize it, and then we have to show results. We have to show the value. That's the process that we're all trying to follow through. And with that, I leave you with some great words. I feel like we are on a journey right now. We are all working towards this common goal, but together we can solve this, and we can solve some really big problems. Thank you very much. We do have time for Q&A, I think. Like 5 minutes or so, or?
Yeah, Dr. Rhew, that was excellent. I think we have about 10 minutes.
Oh, 10. Okay, great.
For questions. And so we've got our runners. If you could just raise your hands, and we'll have one of our runners go to you.
My question is, what is the latest software that can handle all this information? Is there anything that's leading in today's world of what is available that's consolidating all this information for us to interpret currently?
Okay, so let me kind of break that up into 2 questions. If we think of AI as the engine, let's imagine, healthcare's been on a horse and buggy for a while, and now we are actually been introduced to a Ferrari, okay, and it's got this amazing engine. Yes, there's a lot of things that can be done to optimize that engine, but at the same time, the fuel for the engine is the data. And so there actually has to be a strategy around how you improve and expand your capability to be able to get meaningful and high octane data, as well as figure out what type of AI can be applied in what setting. Now, I'm going to introduce an idea that I know some have been thinking about, and we certainly at Microsoft have been thinking a lot about, this concept that, is there a way that we could, if we think about the future as being multimodal data and AI, can we create an environment where the data resides where it's at? I mean, we'd love at some point to bring it all onto one environment, normalize it. It would be just fantastic, but it's just not cost efficient or time efficient. So let's imagine a scenario where we've disintermediated the concept of where data resides and where it's analyzed. If you can do that and bring the copies on that you need to at the particular time, normalize that data. And what I mean by normalize that, I'm talking about things like bring it into standards like HL7, FHIR, OMOP, and be able to do transformations, and then apply AI on top of that. Now you've got a platform that seems to work. And that's something that we've been thinking a lot about at Microsoft, something called Fabric. But I think that what you're going to find is that there are a lot of strategies for how we can solve individual components to this. But I think it's got to have to be data on one side, AI on another, and finding a way that we can start meet you where you're at. Because if we try to expect things that are very cost and time inefficient, we're never going to get there. But great question, yeah. I think we have a runner, so I'm just going to have to rely on whoever the runner can get to.
Thank you for a great presentation. Thinking about, as we're learning to use your analogy to at least drive stick before we drive the Ferrari, I think that there might be a lot of opportunities to empower patients and caregivers to navigate these really complex systems with some of the technology that's already available. So I'd love your perspective on some immediate opportunities in that space.
That is a fantastic opportunity right now, because the challenge that we run into is that patients don't even know what the objective is for a particular, they don't even know what their medicines are for. We have to educate them on every single thing. And a lot of times when we do the education, we do it because we're so rushed. Like imagine upon discharge, they're getting a whole bunch of information and they're giving you pieces of paper, and then we say, we did our job, we educated them. I mean, that's not how people learn. People learn piecemeal. They learn as needed. They learn when you're actually needing to do something at a particular time. That's where technology can help. In the asynchronous ability for them to be able to ask a question in their language at their grade level to say, what am I supposed to do now? I just got discharged. When do I change this bandage? When do I take my meds? It's in the form, but most people don't look at that. So there are tools today. There are tools that allow us to be able to streamline. We may be able to push information. There's some great applications where they've done standardized text reminders to be able to ensure that a patient knows this is the time you have to do particularly. You have to get your medicines, your pre-meds here. You have to stop your food here. I mean, these are the types of things that we know everyone. We gave them a sheet of paper. That's not good enough. We have to go beyond that. And there's so many great tools that we have available.
Great presentation, Dr. Rhew. Like, I have a question, like, more from the research perspective. So, like, when we present some research, like the validation of the method or like reproducibility of a method is very important up there. So, and like mostly like AI is a black box for a lot of people. So means like if we come up with a result out of that, like how do you think like it was better represented in terms of the research? Like, okay, this is how the method is working and this is how we reach to a particular result. And if that result is applicable on one condition, it can or cannot be applicable on the another condition. So my second question comes to the analogy of the engine. So you designed an engine that can run a Ferrari, but that might not run a truck. So how do you make sure that like it is not like wrongly used for, like if it is applicable for one condition, it is cannot be translatable to the another condition. So how do you make a balance among like in terms of your excitement or like that?
Yeah, great questions. These are the things that we are trying to solve through both CHAI and train. But I'll tell you kind of what people have come up with. One is that when you think about how you do the registration, you need to do something called create model cards. Model cards allow you to be able to understand the algorithms, the data sets that they're tested on, because ultimately we know that the data was something that was the key fuel for that engine, and we can't generalize beyond that. That's key. If you don't know what's in your engine, there's no way that you're going to be able to know if it's generalizable. So model cards would be the first thing. Now, the other thing is we have to also understand that explainability of the algorithms is different for different stakeholders. If you were to ask a patient, do they need to understand exactly how an algorithm works? Or if you're asking a developer, two very different approaches. And yet I sometimes think we conflate the two, and we have to say that we have to understand every single thing about this in order for the patients to understand. Patients care more about what you're going to do with their data than they do about exactly how it works. If they say that you believe that it works, they'll believe that. But what they don't want to sort of like walk away with is that data that they just captured, it might go someplace that will somehow get used in ways that I never agree to. That's what people care about. They care about the intent. They care about like that. So that's what's important for transparency. So I think we have to, these are things that we have to figure out. Sometimes people think that just simply putting a little logo that says generated by AI is the answer. Well, that actually may cause more problems and questions. In fact, sometimes AI is being used to help clarify and give information. But then when you see that, your immediate impression is that, oh, it's fake. It was AI generated. So we have to understand that how you communicate this is going to be essential. So there's so much to unpack from that I feel like it's a great opportunity for you to collaborate or for continued collaboration, because ultimately we're going to have to do it together.
Excellent. One last question. I'm so sorry.
Okay. All right.
One last one.
I can add.
Morning. With respect to transparency and evaluations, super important point. So I'm interested in what you're seeing with respect to the FDA and when they're evaluating solutions, how they are observing these principles that you've talked about this morning.
Yes. So first off, AI ML, remember, it's kind of gone down two different paths. And that traditional AI ML, there is a path already that FDA has made very clear with guidance around how to do this. And we're already doing it. It's in medical devices, it's in a variety of other things. So SAMD, all the things that we know of, that's certainly part of it. But what it doesn't do is it doesn't address some of the bigger, broader issues. Things around bias. It doesn't address issues around how we can create a greater level of understanding of like all the AI that's running in systems. And what people are realizing, specifically within the regulatory bodies, is that this is no longer going to be the model where developers test it, send it to the FDA, get it FDA cleared, and then forget about it. It's now going to be developers, it's going to be regulators, and implementers. And that's the reason why I keep bringing it up to all of you, because we are implementers. We are implementing it in our own environments, and there's a shared responsibility that has to occur for all these different things that we're talking about. It is not just about developers figure it out, get it FDA cleared. And so that's become the new realization. That's the reason why you're starting to see a lot of this public-private partnership discussion, because they know, like if FDA sets the bar and says, every model has to be tested on a diverse population around the world, no one, except for very large companies, can get algorithms out there. You will stifle innovation if that was the approach. And so that they have to find that balance for being able to do this, but do this in collaboration with partners like implementers. So great question. I wish we had a good answer. I think the good news is that people are thinking about it, and we're actually trying to think about how we can work together to solve the problem. I am around for the rest of the day. I'll be in meetings here and there, but if you need to grab me, happy to answer more questions. Thank you very much.
Thank you.